Good evening, everyone. Welcome to the masterclass session. And this week we bring about a new case where we are going to talk about an interesting case where we always talk about low platelet counts in the ICU. But this case is very atypical where we are uh, encountered with a normal platelet count, but beyond which there was a lot of bleeding for the patient. And to present this case, we have Dr. Manindra who will be presenting this case, who is a senior consultant intensive care medicine from Yashoda Hospitals, Secunderabad. And to moderate these sessions, we have two expert panelists, Dr. Srinivas Chakravarti sir, who is a consultant hemato-oncology American board certified, working at Yashoda Hospital, Secunderabad, and a well-known seasoned name in the field of critical care, Dr. Suresh Ramsubban sir, coming from Apollo Multispecialty Hospitals, Kolkata, who is also American board certified in pulmonology and critical care medicine. I think probably the right combination where we can see a combined, approach to this patient where a lot of things are involved, where we need an intensivist, hematologist, and a pulmonologist to manage such kind of complex scenarios. Over to you, Manindra sir.
Thank you, Ravi. Thank you for the kind introduction. So I'll just go through the case which we managed recently. Thanks to Srinivas sir, they came for sir. So a 15-year-old female patient came with burning maturation since 5 days, blood in the urine since 3 days, followed by anuria presented to our ER. In the ER, she had a tachycardia with a hypotension, with a systolic blood pressure of around 70, and she had a fever of 102, tachypneic, desaturating on room air, improving saturations with oxygen support, but neurologically appropriate. So in view of hypotension, fluid resuscitation was started, POCUS was done. There was an IVC which was collapsing with a good biventricular function. Again, RV kissing RV, again showing that patient was fluid depleted. Resuscitation done with around 1 to 1.5 liter of crystalloids. Patient was started on vasopressor support, after which the MAP gradually improved. On taking a history, they gave a history of burning maturation for the last few days. So made a diagnosis of urosepsis with septic shock. In view of reduced urine output and anuria, made a diagnosis of prerenal AKI and type 1 respiratory failure. In view of urinary tract infection, patient was started on carbapenems. On taking a history, they told that there was history of recurrent epistaxis and occasional gum bleeding, for which they got evaluated extensively in the past. But most of the times it subsided spontaneously, so they just tended to neglect it. This time also, when they had some hematuria, so they heard about our hematologist and they came to us because this bleeding issue was going on since a very long time. At presentation, the labs were hemoglobin was 8, platelets were 1.7 lakh, PT-INR, APTT were normal. With a bleeding with the PT-INR platelets which were normal and persisting frank hematuria, we did a basic BT and bleeding time and clotting time, and we saw that the bleeding time was prolonged and it was more than 20 minutes. So we had all these differentials in the mind, von Willebrand, Glanzmann's, Bernard-Solier, platelet storage deficiencies, and connective tissue disorders. In the ICU, on day 1, the patient, after some fluid resuscitation and with some vasopressor support, her heart rate reduced a little from 150 to 130, BP stabilized, respiratory rate was still tachypneic, with 26 or 20 to 30 with FiO2 of around 50. In view of increased work of breathing and increased requirement of vasopressors, got electively intubated. Lines were secured. Output was minimal in spite of fluid resuscitation. So in view of platelet count, which was normal, with a bleeding time which was prolonged, we did a von Willebrand factor assay, and we did a light transmission aggregometry also. We sent for CUE urine culture, and even blood cultures. Simultaneously, we did a CT KUB which showed bilateral perinephric fat stranding with upper calyx bleed, and there was a ureteric bleed also with bladder clots. Nephrologist opinion was taken. There was oliguric nephrologist opinion was taken in view of oliguric AK, metabolic acidosis, and shock. Patient was initiated on CRRT. Urologist opinion was taken. Clot evacuation and bilateral degestenting was planned, but in view of bleeding with cause not being clear, we were not sure what was the reason. So we were planning to go slow on the surgical procedure, and conservatively we were trying to manage. In the meantime, we had a von Willebrand factor levels which were normal, and LCH confirmed that with ristocitin, the clotting was good, and with all other things, the clotting was the bleeding, the blood clot was not happening. So we made a provisional diagnosis of Glanzmann's thrombasthenia. We started on vitamin K, factor 7A, tranexamic acid, and desmopressin. Over day 3 to 6, shock improved gradually. Shock improved gradually. Urine output also started improving. But patient had persistent hematuria along with decreasing hemoglobin levels. And on day 3 to day 6, patient had new onset thrombocytopenia. Platelets and recombinant factor 7 infusion were continued with daily doses, but the CRRT was changed to SLED because the hemodynamics improved. There was mild bleeding which persisted from endotracheal tube, but the dosage of factor 7, we were only able to give around 1 mg to 2 mg on a daily basis because of logistic issues. Day 7 to day 10, patient had profuse bleeding from endotracheal tube followed by arrest, revived after 1 cycle of CPR. Tube was exchanged. Patient had persistent low PF ratios post CPR because of bleeding inside the lungs, as a result of which he developed moderate ARDS. 1 session of proning was also done. Responded to proning well. PF ratios improved. In the meantime, we got a blood culture which showed a CRE. So the antibiotics were upgraded to aztreonam and avibactam. In view of persistent drop in hemoglobin with bleeding manifestations, low platelets, raised INR, and low fibrinogen, patient was transfused FFPs, matched leuko-reduced SDPs, and PRBCs. Day 10 to day 13, shock improved with minimal NORAD support, AKI improved, ARDS also improved, persistent mild bleeding. In the meantime, I missed mentioning, I think day 8, we went for bilateral degestenting. We tried weaning attempts, but there was a little bit of weakness. So we failed weaning attempts during these days. But in view of bleeding, we continued giving factor 7. Day 14, patient gradually improved and fortunately got extubated. Still, she's in the ICU with minimal hematuria. Over to you, Ravi. Ravi?
Hello. Yeah. Can you hear me?
Yeah, now we can hear you, Ravi.
Yeah. Sorry. I think we have gone through the case. Now, we'll try to understand, what are the things which we commonly come across in our ICUs. So the first question to Suresh sir, why is, Glanzmann's thrombasthenia often missed in the ICU?
Because I think this number one reason is we don't know about it. That's, I think, the commonest reason. Ignorance is bliss. I think once we look at disorders. I think more importantly at our level, I would leave it at saying, is this if somebody is bleeding, is this because of platelet dysfunction? If it's not a qualitative platelet dysfunction, it's not a quantitative platelet dysfunction, is it a qualitative platelet dysfunction? And that question has to be asked, provided if somebody is bleeding. And that's a question which we don't frequently ask. We only look at numbers. So there is an issue of us not being aware of a qualitative platelet defects and having looked at numbers. So when we are a number oriented specialty.
Yes, sir, absolutely true, sir. Because we always look at the platelets and the PTINR, APTT, if they are normal, then we go beyond that. That is, I think, the probably common point what you rightly have mentioned, sir. Then the other question would be to Srinivas Chakravarti, sir. So when should we have a suspicion that this could be a probable Glanzmann's thrombasthenia?
Am I audible?
Yes, sir.
Yes, sir.
So yeah, so when do you not just Glanzmann's thrombasthenia, when do you suspect qualitative disorders of the platelets? So I disagree with Dr. Suresh. You guys are as much about quality as you are about quantity. So are we. So recurrent mucocutaneous bleeding. Broadly speaking, there are two kinds of recurrent bleeding. One is mucocutaneous, predominantly in the mucosa of the mouth, nose, GI tract, urinary tract, and in the skin. The other kind of bleeding is what's called deep bleeding. That happens into the muscles typically, or into the joints. Typically, when somebody has recurrent bleeding into the muscles or into the joints without any other explanation, we suspect a clotting disorder like a hemophilia. But when somebody has recurrent mucocutaneous bleeding, we have to start suspecting either a quantitative or a qualitative defect in the platelets. Now, first thing we all look at is numbers. Hematologists do, ICU people do, everybody does. But when the numbers are okay, then we typically, ideally, we do what is called an ISTH-BAT bleeding questionnaire. For those of you who are uninitiated, which I'm assuming is all of you because you're the ICU gang. It's the International Society of Thrombostasis and Hemostasis bleeding assessment tool. Now, this is available in MDQ. This is available all over the internet. It's a scoring tool which kind of asks specific standardized questions about the kind, frequency, and severity of bleeding that you had in your lifetime. This is ideally done in the clinic, not in the ICU, because once you're intubated and your BP is down, you can hardly answer questionnaires. But you can do it with the family. So typically when they're present in the clinic, this is what we do, the ISTH-BAT questionnaire that gives you a score. So the score of more than 6 in a woman would be very suspicious, highly suspicious for a qualitative defect of the platelets. So that's when we start investigating for a qualitative defect of the platelets. First thing is, of course, clinically, frequently we find that they're on medicines like aspirin, that people take aspirin for headaches, people overdose on indomethacin or something, brufen for aches and pains, so on and so forth. So history is essential because frequently it's iatrogenic. Remember, rat poison also can cause qualitative defects of the platelets. Alcoholism also can cause qualitative defects of the platelets. So apart from the history, what if it's not obvious in the history? Then the next step, typically we do what is called the platelet function analysis. So there's something called the PFA 100, PFA 200, depending on which machine you use. Now, this has by and large replaced the bleeding time, clotting time. In my opinion, bleeding time and clotting time, for the most part, are useless tests. They belong to the Second World War, not 2026. They're not standardized. Have all of you guys done it in physiology class? We all went through MBBS, right? I'm from Osmania, so I remember the days when we took that filter paper, pricked your partner, and they took that filter paper and kept on blotting it, and then you measured that time with a stopwatch and all that. Now, most of our technicians, please remember, have 6 months of training. They're post 10th class. They have 6 months of training. They're expected to know every test. Tests like this, they cannot perform well because highly manually dependent. Second of all, the test itself is not standardized. So there's a lot of false positives, false negatives in the bleeding time, clotting time. So the platelet function analyzer kind of fixes that. It's a standardized small fiber tube that mimics a blood vessel, an arteriole. So it's coated with collagen. So you basically take a very small sample of the patient's blood, pass it through the tube, and you see how it deflects light and under high shear. So the shear mimics the way blood is passing through a blood vessel. The tube itself mimics a standardized blood vessel. And because it's collagen coated, and you expose it to ADP, which mimics breakage in the blood vessel. That means you're creating in an artificial setting, you're creating a real life situation where you have a damaged blood vessel. And because all the measurements are standardized, you get a more standardized timing. So you look at what is called the closure time. How long it takes for the blood to clot. It's very simple, very effective, standardized. So this is what is the first thing we should be doing now when you suspect a qualitative defect on the questionnaire, on the questionnaire score, the bleeding assessment tool, then you do the platelet function analyzer. If that suggests a qualitative defect in the platelet, then you go ahead and you do what Manindra mentioned, the light transmission platelet aggregometry. There you basically have a laser light. So the platelets are exposed to different kind of agonists. Typically, we like to look at ADP, collagen, adrenaline, and ristocetin. Those are the 4 standard ones we look at, although you can look at other things also like thromboxane, prostaglandin, so on and so forth. But these 4 are the standard. And you expose the platelets to these different agonists, and you send a laser beam through that, and you see whether aggregation is happening or not. So that's how we differentiate between the different qualitative defects of the platelets. So for example, you have a deficiency to ristocetin. That is von Willebrand factor deficiency typically. Then you do other confirmatory tests for von Willebrand factor. Remember, as far as qualitative defects in the platelets are concerned, von Willebrand disease is the commonest one around the world, especially type 1. That's the Glanzmann is very rare. Von Willebrand is actually the most common qualitative defect of the platelet. So most often in the ICU, you'll be seeing that rather than Glanzmann when you have a qualitative defect. There, the deficiency of aggregation is to ristocetin. It's intact with the other ones. In Glanzmann, because in Glanzmann, you have a congenital deficiency of the glycoprotein 2B3A on the platelets, which is crucial to bind fibrinogen. So 2B3A exists as a dimer. In the resting phase, they're inert. When the platelets are activated, they heterodimerize. They heterodimerize and come together, and they form a binding platform by fibrinogen molecules. So fibrinogen sticks one end here and one end to another GP23A, activated GP23A. So they form, so the fibrins form a bridge. Then the thrombin is released, also mediated by the platelets. The thrombin stabilizes these fibrin bridges, and that's how you get a stable clot. That's what happens in the body. Now, when this 2B3A is missing, platelet activation with any agonist will fail to cause aggregation, except ristocetin. That's because of von Willebrand is not dependent upon 2B3A. So ristocetin aggregation will be okay. The aggregation will not be okay to ADP, collagen, or to epinephrine. That's how you specifically diagnose Glanzmann's thrombasthenia.
Yes. We'll come over to the diagnosis aspects, sir. The next question, probably I think you have answered. Probably I think that's part of pathophysiology, what exactly happens in the Glanzmann's thrombasthenia. So what other disorders we should be suspecting in addition to Glanzmann's thrombasthenia when the platelet count is normal and when we have a normal PT, APTT, and an INR, which are typical coagulation tests what we routinely do in your ICU.
Correct. So if you have in the ICU, somebody is bleeding persistently, you have ruled out all other common causes, and you have a clinical suspicion that this is a qualitative platelet defect. I repeat again, many of these cases are iatrogenic. We got to consider what medicines are we giving that can cause platelet dysfunction. If that also has been ruled out and you suspect that there's an inherited or acquired problem with thrombasthenia, then von Willebrand disease, as I said, is the commonest. Remember, there's an acquired von Willebrand disease, which is actually common in the ICU. It's not uncommon. Frequently goes undiagnosed, but it is not uncommon in the ICU. Old age can do it. Autoimmune disorders can do it. A variety of antibodies can cause drug-induced antibodies can also cause an acquired von Willebrand disease. So that's the number one thing that you need to look at. The other thing is Bernard-Soulier, Glanzmann, and so forth. These are the main ones that you look at as far as platelet defects are concerned. Glanzmann, remember, again, I repeat, is quite rare. We're discussing this case and we're going to talk about it, but it's in fact very, very rare.
So I think the classic laboratory findings, what we come across when you have a case with the Glanzmann Thrombasthenia.
Correct. So the platelet function aggregometry, that's the key. I remind you guys again, so we start with the bleeding questionnaire. You do a score. The score will tell you whether it is reasonable to suspect a thrombasthenia. If you do suspect a thrombasthenia, you do a quick screen with the PFA 100, in which the pathognomonic sign of Glanzmann is that aggregation is not present to any of the agonists except ristocetin. Now, you can confirm this. So that's considered the gold standard. If you're still in doubt, you can confirm it by flow cytometry. Flow cytometry, we generally don't do these days because flow cytometry is inferior to the light transmission aggregometry. What the flow cytometry can do is it can give you ancillary information and it can quantify the amount of basically GP3A, GP2B amount. So you can actually classify it into mild, moderate, severe, and so forth. But since that does not have much clinical value for us, and because flow cytometries generally are not standardized, I mean, you need to have a high volume flow cytometry center where your gating strategy is appropriate for this and all that. We generally don't have that in Hyderabad. So normally we don't do flow cytometry for this. What we can do to confirm is a genetic test. Nowadays, genetic tests are available. All Glanzmann thrombasthenias are caused by mutations in either one of two genes. And testing for those genes are available to find which mutation is present in which gene. So hundreds of mutations are described in Glanzmann thrombasthenia, but all those mutations happen in only any one or both of these two genes. It's an autosomal recessive disease, which means both parents should have Glanzmann thrombasthenia gene defect for the patient to inherit it. So our patient that we discussed is the product of a consanguineous marriage. And so although we go around saying that Glanzmann thrombasthenia is very rare, it's actually found much more commonly in areas where there's a lot of consanguineous marriages still in rural Telangana, many parts of rural India, Pakistan, so forth. So the gold standard is the light transmission platelet aggregometry. That's the gold standard for diagnosis. The confirmatory test is a gene mutation analysis.
So I think probably you have already highlighted this, sir, the stepwise evaluation of platelet, disorders with a normal count.
Mm-hmm.
As you said rightly, probably the first thing what we would look at is, first von Willebrand factor, which is more common in our ICUs.
So
and then
you should be putting the bleeding questionnaire before that.
Yes, sir. Yes.
I can put that in the chat for you. You guys, anybody can Google it. It's called the ISTH BAT.
So
it's standardized and fairly commonly used now by hematologists around the world. So that's obviously not too valuable in the ICU, but definitely if you're meeting somebody in the clinic or you're interviewing the patient's attenders, you can definitely use this tool, which is the first clue that you have a platelet qualitative defect. And then you do the platelet function assay, and then you do the von Willebrand panel and the light transmission aggregometry.
Yes. So probably I think like you said, bleeding and clotting time has been replaced by platelet function assay, followed by gold standard light transmission aggregometry. Then I think I'll not go there. As you said, probably I think we are only looking at flow cytometry to confirm, probably the variants and detailed analysis if required, sir. Hope I'm true.
Yeah. Well, it's not confirmation. It's an ancillary test because flow cytometry is heavily dependent on the gating strategy of the biotechnicians. So because of that, the flow cytometry also has a false positive and a false negative. So it does not replace, and it cannot be the light transmission aggregatometry is actually the confirmatory test. So it does not replace the light transmission aggregatometry, but it can give you ancillary evidence. It can tell you quantitatively how much 2B3A is there, if that helps you clinically. Normally, it doesn't help us clinically because we already see a severe bleed is a severe bleed. There's no point finding out how much. It's not like see, when you have a coagulation defect, for example, factor 8 deficiency, hemophilia A, patient is bleeding. I want to know what is the amount of factor 8 in the patient's body. Yeah, why? Because it makes a clinical difference to me. So I calculate my dose of replacement by factor 8, recombinant factor 8, based on the amount of factor 8 that they is. Now in Glanzmann, you can't do that. So there is really no practical utility to doing flow cytometry, which is why we generally don't do that. The confirmatory test is a gene test, which is done by MedGenome, Core Diagnostics, and people like that. It's readily available now.
Okay, sir. So I think, genetic sequencing, like you said.
Right, correct. ITGA2B and ITGA3.
So question to Suresh Ramsuban, sir. Sir, can we use TEG or ROTEM in such kind of patients? Would it be helpful in these scenarios, sir?
I think TEG is a much better assay of the entire process of. Can you hear me?
Yes, sir, we can hear you.
Yes, sir. Yes, sir.
Yeah, so better process for the entire coagulation cascade, because of the fact that you're looking at the fact that instead of looking at the extrinsic you're looking at the R time, the K time, the alpha angle maximum. You can divide the TEG graph into a problem of a coagulation, a problem of fibrinolysis in the middle part as a platelet. So if you look at the maximum amplitude, if the vertical amplitude in this thing, it gives us an idea that there is a platelet. We use this very commonly in our liver dysfunction cases, as we mentioned, where you might have a normal platelet count, especially in a liver transplant setting, in a CLD patient, where you might have a near normal platelet, but they're bleeding. And there is a significant where we use the vertical amplitude of the TEG, the maximum amplitude, and which normally should be about 50 to 70 millimeter. And if it's less, then we know that platelets, or even when we use DDAVP to improve the function, we can use the amplitude of the maximum amplitude to see whether the DDAVP is working or not. So you can have the TEG has definitely, I feel, in the intensive care unit, a significant role in understanding what is causing this bleeding. And when you're treating also, say, for instance, as I mentioned, when you use an agent like a DDAVP to prevent for platelet dysfunction, we use that in uremia. We use DDAVP in a lot of other situations where you're bleeding because of platelet dysfunction. In this situation, probably you would have used a little bit of DDAVP to stop the bleeding. So in that situation, when your maximum amplitude goes up, you know you got an adequate dose of DDAVP in. So I think TEG is not to diagnose the platelet dysfunction, but if you're, say, probably using it to treat it, you probably have a better understanding as to what's happening in this situation.
Yes, rightly said, sir. Then we'll move on to the treatment options, sir. Suresh, sir, if you come across such a patient with a major bleeding, then probably what would be your targets, and I think probably I'll then move on to specific therapy options to Srinivas.
So as I said, it's much easier to, if this were a number issue, I would say platelet goal more than 50K, INR more than 1.5. It's much easier.
Yes.
Here you don't have a number problem, and I think that's where the key is, and they understand how to do it. So you got to stop the bleeding, and so if you're actively bleeding, like say in this instance, say if you're bleeding from the lungs, you really very difficult to say what is the right amount of platelet that you need. This general rule to have we used to say that when we used to use factor 7A, Novo 7, recombinant factor 7 as water in the early 2000s, would be to say have a minimum platelet of 50,000 for the recombinant factor 7 to work, and then say, all right, whatever is a defective platelet will work. But I would probably still keep that number or move that the minimum number that you need, a quantitative number of platelets should be about 1 lakh. 50,000 to a lakh. That's where probably you're looking at the minimum number where you can say some amount of bleeding will be stopped. Because, or let's look at it and say that whatever platelets the patient has is not functional. So let us replace him. When somebody is bleeding, let's give him enough unit to prevent bleeding, which would be about 20 to 50K. So I'm assuming that whatever platelet this patient has is not working. So that means he has got zero platelets, because it's a numbers wise he might be 1,40,000, but the actual efficacy of these platelets are not there. So I'm going to replace the number with good platelets from a donor, and there is going to be a one single donor platelet to get about more than 20K up, and then use a factor 7A to stop the bleeding, to make as a universal hemostatic agent. And once the factor 7A and this new platelets form a clot, I'm going to keep the clot stabilized with a little DDAVP. And to prevent that clot from fibrinolizing, I will use a little of what we call as a pause or a tranexamic acid. So that is the whole idea that you want to do. You want to give platelets into the patient, then you want to give a universal hemostatic agent like a Novo 7 or this thing. Once the clot is formed, you want to strengthen the platelet clot with the DDAVP, and you want to prevent fibrinolysis with this thing. And obviously, you give coagulopathy. If there is a associated coagulopathy, you give plasma. If you find that the R time is difficult or is slow, then you give a little plasma. If your INR is prolonged, you might probably, again, with this, probably if you're using tech, then just use the R time to give whether this thing. And if your K and alpha is a problem, give some cryo. And this is how I would do the whole bleeding management in a patient with a bleeding, active bleeding with a qualitative platelet dysfunction. We see this also with somebody who's on a dual antiplatelet who have come in with major bleed, and we kind of use the similar thing in a background of liver disease on dual antiplatelets. We assume that the function of the platelet is not there. So we do give some platelet, though the ICH guidelines and everything says don't bother, but a lot of us would say give some good platelets and then keep the platelets in the system and get a good clot. That's the whole idea.
Srinivas sir, I would like to
caveat
ask.
number one: be very careful with platelet transfusions in Glanzmann Thrombasthenia. So when you are suspicious that there is a platelet function defect, there's a qualitative defect. In general, whatever Suresh said is true. In general, it's a qualitative defect, but you're giving enough good quality platelets that you form a clot, give whatever it takes to form a clot. But the problem with Glanzmann Thrombasthenia is, it's important to make the diagnosis first, is because 2B3A, they produce a receptor that belongs to the alpha integrin family. This is highly immunogenic. So when you give platelets, you rapidly alloimmunize the patient, and the platelets will stop working. Any platelets will stop working because you're forming antibodies to the platelets. So you have to be very, very careful when you give platelet transfusions. So typically in Glanzmann thrombasthenia, platelets are not a knee-jerk reaction. They have to be carefully considered, generally given for massive bleeds, life-threatening bleeds, or where it really matters. In this case, this lady did deserve it, obviously. But when you do give platelets, you have to make sure, as far as possible, it's single donor platelets. The reason, not random donor platelets. Again, the reason is immunogenicity. By keeping it to one donor, you're reducing exposure to multiple antigens. That's one thing. Second thing is, ideally, they should be HLA matched. Very difficult in our country. It can be done. We have done it. I was in Apollo before this. We've done it quite a lot in Apollo, and we're trying to do that in Yashoda as well. But ideally, we should be giving HLA matched platelets. Platelets don't have type 2 HLA antibodies, so it's enough to match class 1 antigens. The reason for that, again, is to minimize alloimmunization. So platelets should be given in Glanzmann thrombasthenia only in difficult situations. Single donor, never RDP, and ideally HLA matched. The second caveat is, now these antifibrinolytics and DDAVP in somebody with bleeding disorder and bleeding in the genitourinary tract, be very careful with using antifibrinolytics and DDAVP. Now, this patient, in retrospect, when she started having, before she presented to us and in the ICU, she started having urinary tract bleeding for 3 days. Her doctor did suspect a platelet dysfunction, and he said, just take tranexamic acid and DDAVP. Now, the reason that you need to be careful with the fibrinolytics and DDAVP in bleeding disorders of any sort, bleeding in the genitourinary tract is exactly what happened to this patient will happen. You'll clot, they will obstruct, you'll go into renal insufficiency. So ureteric obstruction is very common when you use antifibrinolytics in a bleeding disorder patient. So be very careful with somebody with a bleeding disorder, has a genitourinary tract bleeding. Be careful. It's probably not good to use it in the outpatient setting, the antifibrinolytics and the DDUP. The rest of it, I agree. This particular patient, on top of Glanzmann Thrombasthenia, actually developed DIC. She had proven DIC with high FDBs, high TT, and low fibrinogen levels, and that's why she got the FFP to maintain her, to normalize her PT. So thromboelastography, I agree, is very, very useful. Generally, our cardiothoracic colleagues have it because apart from the liver transplant team, the ICUs, the cardiothoracic surgery teams also use a TEG a lot because they don't know what caused their bleedings. So it can very quickly, it's a rough and ready bedside thing that can very quickly tell you whether the bleeding is predominantly vascular or platelet or coagulation defect. And you can also use the TEG to check your doses, the doses that you're giving.
I think the next question would be to Srinivas sir. I would like to ask, role of, recombinant or Novo7 in such patients, because I think probably you have discussed about platelets and tranexamic acid.
Yes.
Probably then.
So factor 7A is kind of the quick fix. It's the fix all. It's like doctor fix it's universal, anti-water sealant kind of thing. Because if you remember your coagulation cascade, and I consider you extremely abnormal if you do remember your coagulation cascade. We all of us hate it, of course. But if you do remember it, the formation of activated factor 7 is the final step in the coagulation cascade. That is actually what leads to a stable fibrin clot. And that is the ultimate goal of the entire coagulation cascade. So you're pretty much bypassing all other steps and going to the end when you use factor 7A. So it works marvelously well in a variety of kind of bleeding disorders, including in Glanzmann's. In Glanzmann's, it's particularly useful because it also causes what's called a thrombin burst. So there is a sudden intense release of thrombin from the platelets, which is also the job of the normal platelet. In Glanzmann's, frequently, the thrombin release also is deficient. Apart from the 2B3A, missing 2B3A, there is a deficiency in the amount of thrombin that is released. So by facilitating the bridging of the fibrin clot, stabilizing it, and by causing this intense sudden thrombin burst is how factor 7A acts, and that effectively bypasses the defect caused by the 2B3. The ideal the published dose of factor 7A, and I have to tell you that these are mostly, so factor 7A is made only by one company now, Novo Nordisk, Novo7. So most of these trials are funded by the drug company. So the dose that they publish is about 90 micrograms per kilogram body weight. And you're supposed to repeat it every 2 to 4 hours, depending on the amount of bleeding you have. Okay? You can't really measure the activity of factor 7A, even by TEG, although you can try, I guess. What we really look at is the clinical amount of bleeding that's happening and then decide whether to go on the dose or not. Having said that, 90 micrograms per kilogram is extremely expensive in this country, and in any country for that matter. And that may not be required because different people have different amounts of factor of GP2B3A. So as little as 10 micrograms per kilogram can also be effective. So that's typically what we do when we are cash strapped. We use the lowest dose, the 10 micrograms per kilogram body weight dose, which was the dose used for this patient, which is why am I still audible?
Yeah.
Yes, sir.
Can you give me just a second? I think I'm getting a call from.
Yeah, going with saying we never use 90 microgram. We just can't afford it.
I can't. That's for sure.
Even availability of such a high dose is also,
It's
Very
available.
rare in hospital
It's
settings.
available. You can. It comes in 1 milligram and 5 milligram vials, and you can inform the company in advance. It's like the hemophilia factor 8. You have to inform the company in advance. 45 minutes they'll make it available. That's not. So availability is not a big issue. It's not even as bad as factor 8. A lot of neurosurgeons use it, by the way. So it's available in the market. They keep it.
All surgeons love it. It gives a beautiful field. For 2 hours, there is absolutely, you can cut wherever you want.
Absolutely. Actually, they love it more than hematologists do.
Yeah.
It's we who keep objecting. But that's the reason why it's widely available in the market, and availability is not an issue. Price is the issue. So 10 micrograms per kilogram body weight is where we begin, and then we titrate up every 2 to 4 hours, depending on the amount of bleeding that we have. So that effectively comes to around 1 milligram for this patient. So we rounded it off to 1 milligram vial, and that's what we used. Unfortunately, even that they could afford only 1 vial a day. So that's what we ended up giving. It worked in the sense that our bleeding did decrease. I think treating the infection and even this amount of Novo 7 actually helped her.
I think regarding the dose in such category of patients is another question, sir. Like you said, probably, repeating is one, thing which is very difficult in our setup. Then what should be our target? Is it just pure bleeding, or is there another target what we are actually looking at, sir?
So the commonly used target is the bleeding. It's the clinical amount of bleeding, because there is no test that can actually predict the amount of bleeding that will happen. So clinical assessment of the bleeding is what, in this case, it's not particularly difficult because she's bleeding in the urine. We can quantify that. She was bleeding in the ET tube. We can quantify that also. But alternatively, here is where you can use your flow cytometry to quantify. If you're giving platelets, you can quantify the amount of 2B3A by using flow cytometry. How many platelets do you give to maintain at least 10% 2B3A flow cytometry? Or you can use the TEG.
Okay, sir. So the next question to Suresh, sir. Sir, if you encounter such a patient in your ICU, would you be concerned about doing any particular procedures in such category of patients where you are more worried or more cautious?
So I think for giving an epidural analgesia would be something which I would not go near this patient. So any neuraxial procedures, I would be really, really wary about it. They got to do lines. You really have no choice. There are certain issues we do. I know we have CLD patient with 10,000 and INR of 10 whom we do lines. So there is no issues with that. We are used to doing procedures, especially vascular procedures. We are very good with ultrasound and with prophylactic things. So here probably giving a prophylactic, as I said, maybe if you're really worried about a very high risk procedure, maybe even using a little Nova, this thing would be important. As I said, for this thing, but the airway procedures, intubating these patients or putting a central line and art line can be avoided because it's probably a little bit more the same. But central venous access, we do this all the time. The problem is not it's not the issue of this thing, it's the bleeding from the skin, the surfaces, and the ooze, and the general diffuse bleed that will keep on happening. And that's where the problem is. So you're just adding one more site from which this patient can bleed because of a platelet. So any procedure which is avoidable should be avoided. And I'm not very sure again because of the fact that if you're as I said, the surgeons love to get a clear feel, but all these things with this Novo 7 is the fact that you're going to last only a couple of hours, and there is no as I said, giving platelet, as we just realized, is that it's not really effective unless you have you're just going to create allo antibodies, and giving pause again is going to create thrombosis. So really, if you really want a clear 2 hour window to do any procedure, go ahead and get an over 7 one more dose. Again, don't know what will be the right dose for that. But neuraxial procedures, I'll probably be extremely careful. If I need a surgery, I'll just probably go ahead and just do it under MAC, or go ahead and intubate and ventilate the patient. That's probably the best thing I would do.
Then probably we will encounter another two category of patients, sir, Srinivas sir. So one is patients with an intracranial hemorrhage or a massive obstetric hemorrhage. So, do we do anything particularly or selectively in such category of patients, sir?
Full dose factor 7A. So immediate STP transfusions, then maintain with full dose factor 7A and titrate it according to clinical improvement. So as was said, neuroaxial and ophthalmologic bleedings have to be taken obviously very seriously because they cause permanent damage or death. So we give the maximal doses and titrate down rather than give low doses and titrate up. And here you do not save platelets, elimination, no elimination, saving the life is important. So you go ahead and give SDP as and when it's available.
Then, as we, come to the treatment, it always comes with certain risk. I think probably that is the risk what we have been discussing about, although we routinely use tranexamic acid or recombinant factor 7 activated, uh, is there any specific risk with these agents? And
Thrombosis.
if you have to use such agents, what we would be actually looking at the risk-benefit analysis here, sir.
Yeah. So
No, the whole crash 2 trial, sorry, go ahead. The whole crash 2 trial was designed to prove that tranexamic acid is safe. So
correct.
Before crash 2 trial, we were very, very skeptical about tranexamic acid. And what crash 2 trial showed us what tranexamic acid is safe in trauma in a bleeding situation as far as thrombosis is concerned. But a generation of people, including me, who grew up before the crash 2 trial, would be very, very wary of using tranexamic acid, especially if you have a elderly patient and thrombosis is a big issue. So both tranexamic acid and a universal hemostatic agent like factor 7A, it is going to be an issue. DVTs, MIs, cerebrovascular accidents are all going to be part of it. But again, I think its life is a double-edged sword. So are you going to die from bleeding or you're going to die from thrombosis? You got to pick your devil and then decide what you're going to do. But yes, that's what I would say that. So yes, we really have to be careful about going gung-ho with tranexamic acid. You don't need to, and gung-ho with the high doses of factor 7A, just have to be understanding where we are. And as we rightly said, the bleeding has to be quantified, and the ISTH, and when you look at the various classification of say bleeding with say Clexane, we always say it's a minor bleeding or a major bleeding, and there are well defined criteria to say major bleeding and minor bleeding. So do not be aggressive about treating minor bleeding because you really cannot take care of it. Major bleeding, be very aggressive with all the 9 yards. That is the only way we can balance it.
So add to that, fibrinolytic agents are in general fairly safe now. So we do have no hesitation using it. But remember, they do come with risks, and they are effective only in mild to moderate bleedings. So that's where you would use it. If in severe bleedings, they just have an adjunctive role. They don't have a major role. In serious bleeding, you have to use factor 7A. Factor 7A, the major risk is that of clotting. You will have cerebrovascular accidents. MIs have been reported. Intestinal ischemias have been reported, so on and so forth. DVTs have been reported. CSVTs have been reported with factor 7A. But again, everything is a risk-benefit balance. When then there is imminent danger from the bleeding, you don't hesitate. You go ahead and give whatever you think is clinically the appropriate dose.
Yeah. Another common scenario which we come across is, patients like this patient who had multiple procedures, who was intubated, has gone for surgery. Probably, I would be worried about, she landing up with a thrombotic complication with the use of tranexamic acid and factor 7.
Right.
And, we always talk about, prophylaxis for DVT. So how do we, use, what would be the ideal way of preventing VT in such category of patients, sir?
So in effect, this female already had thrombosis. Her ureters are blocked because of thrombosis. It's probably because of fibrinolytic use in the outpatient setting, because she used both DDAP and the fibrinolytic agents in the outpatient setting. Now that we would luckily be able to retract and stent successfully. The kidney function improved eventually, and she was successfully able to stop the dialysis. But this is a difficult situation. Generally, we do not do DVT prophylaxis. Unfortunately, either a qualitative defect in the platelets or even a quantitative defect in the platelet does not protect against DVT. That is a clinical problem that we all have to face. So, for example, platelet counts are 10 in rip-roaring ITP. In fact, your risk of DVT goes up, it doesn't go down. But because remember, in ITP, a certain percentage of people actually do clot, they don't bleed. That's because of the activated factors that are released from the lysine platelets. So low platelet counts or qualitative defect in the platelets are not a protection against DVT. So the DVT risk remains. However, having said that, because the risk of bleeding is more imminent, we generally do not prophylax these patients unless they're at very, very high risk. If we do have to, if the DVT does happen, as it can, and you do have to treat it, then we typically use a short-acting low molecular weight heparin. Clexane is the universally used. It's the most commonly used, the one which is widest experience. And you can actually monitor the anti-factor 10A levels to measure Clexane activity, enoxaparin activity. So you ideally draw it about 4 hours after you give enoxaparin. And you can monitor, not the PTT, because that's not reliable, but you can monitor the anti-factor 10A levels and titrate your Clexane dose to that to get adequate DVT treatment in the face of a bleeding disorder.
So, I mean, the question, when should we call hematologist in such situations?
You don't ask such questions to the hematologist present.
These kind of diseases where I cannot even spell the disease, I would call them.
Yeah,
I think it's absolutely, because I think this is where a specialist comes in. And the issue is that, as we rightly said, I wouldn't know about alloimmunization. I wouldn't know that the platelets have an HLA can be done. So there are issues which most of us, we are practicing good level of intensive care unit, but there is what is called as a specialty which they need to be involved right away in this patient. So I have no doubts about it. There is no reason why we should try to we should be co-managing this patient. We should be taking their help right from the beginning. There is no doubt about it in this. I think there should be no hesitation in this.
And that I think probably when we handle such patients, probably I would be also interested to optimize this patient, because we are sending such patients for surgeries if required, unless they are emergency. So what optimization would be looking at when we are planning for an emergency surgery in such category of patients, or probably say elective surgery in the form of cesarean section also. So what are your targets, sir, in such category of patients?
No, as I said, the target is very simple, because you probably would have a baseline tag to understand where they are, and before you go ahead and get a surgery, you will have a baseline complete blood hemoglobin, and you want a target hemoglobin of more than 7 to 8 to start off the surgery with, and you would probably want to have the coagulation parameters corrected. And then, as we rightly said, that we will, if the surgery is whatever be the surgery, we would want to give a get the optimization by at the time of induction. You probably want the factor 7 to go in, the recombinant factor 7 to go in, so that you have a clear field for the next couple of hours, so they can do this thing. That would be the best way of looking at surgical optimization, because otherwise this patient is never at any point in life from this age of 15 till she actually, whenever she as long as she lives, she's going to be a high risk for bleeding from any incision that you give her. So that is the only thing we need to be aware of. If she needs an essential surgery, she needs it. Of course, the epidemic of DJ stenting is rampant everywhere. So the indication for a DJ stenting is an obstructive uropathy. So unless you have obstruction, and the obstruction with a clot, I'm not very sure. That's something which you may not be. Yes, obstructive pyelonephritis, obstructive this thing, it requires a DJ stent, and fair enough. But that is an epidemic that is going on in our country.
Yeah,
We need to be careful.
Patient probably didn't require. It's an acute clot. It's an acute obstruction. Retraction would
Fair.
probably have been sufficient, but then we are not in the field. We don't make the.
And ARDS, I'm not willing to agree again, because one of the mimics of ARDS is diffuse alveolar hemorrhage.
Exactly.
So if you call it as a DAH, then it's a bland DAH, because it's a platelet dysfunction. It's not an immunological dysfunction. A bland DAH is managed in the same line, but we don't have data to say that proning. So this is a mimic of ARDS, and that should be something which is, because ARDS is a syndrome and specific. But yes, if you're bleeding, then it's proning and all becomes a little bit more dangerous, because if you're actively bleeding, suctioning becomes an issue. So here, I think the principle of, and obviously getting a patient onto an ECMO and putting them on blood thinners becomes difficult. So yes, a DAH becomes a difficult issue in management. As I was talking to you before, so if it is bleeding and you put in a scope and you have more than 25% of the bowel fluid showing hemosiderin laden macrophages, or what we call as the classical triad of DAH. That means you have got a bilateral alveolar infiltrates, an ARDS physiology, a drop in hemoglobin, and hemoptysis. Hemoptysis may not be present in all. In the absence of hemoptysis, if you have a hemosiderin laden macrophages in more than 10% of your alveolar lining cells, macrophages, then you know that it is a DAH. And the treatment for DAH is to prevent the further bleeding and to stop the bleeding. If it's immunological, you stop with immunological agents, and in this situation, you would stop it with again a recombinant factor 7. That's the only thing that will stop the ARDS DAH from getting worse.
Yes, this
Sorry about
patient
that.
more likely had an alveolar hemorrhage rather than
Correct.
ARDS. She was actually bleeding from the ET tube, and she didn't exactly meet the parameters for the syndrome. So,
Correct. So we would like to call it as a DAH rather than an ARDS. Yes, be careful boarding such because actual art of suctioning. When you use suction, use blunt Nelaton catheters which don't have a which don't get into the which don't suck in more the mucosal epithelium. So you have to be very careful about suctioning. So one of the things that we would like to teach our this thing is that in this kind of a situation, be aware of using the largest possible suction catheter bore with the blunt tip and a side hole to suction rather than a front hole to suction, so that you don't cause any mucosal trauma. And it has to be a low suction, not a deep suction. A deep suction should be done under the supervision of a physician, because the more you go blindly with endotracheal tube and start hitting the carina, the more the bleeding will happen. So I think if I have to say what is the best management for this patient, it is that suctioning should be done by the senior most doctor rather than by and not to do any other things which will cause mucosal bleeding. Remember, the mucosa that bleeds the easiest is the bronchial mucosa. So you just have to touch it with a scope and it bleeds. And in this case of cases, you just have to touch it with a suction catheter and apply suction. You will bleed torrentially. So the message that we should get across when you have a bleeding disorder is be very careful about proning, and more because you're going to make it difficult to do suctioning because of whatever the issue. And suctioning has to be done under the supervision of the best physician, best nurse possible to do it. Has to be done with a blunt ended suction and no deep suction unless a physician is present.
Just to add on, so basically the event happened late night at around 9:30, and in the night at 1 o'clock, my team was not able to ventilate the patient with plateaus going up. So
yeah, fair enough. I'm not saying that it's this thing, but because it's a alveolar hemorrhage and it is we don't know whether the blood density. Yes, we understand that when you have a bleeding, so they understand the proning physiology is that the dependent areas. ARDS is a heterogeneous disorder with a super dependent on the prone areas because of the distribution of gravity that you have. So I'm assuming blood will also flow according to gravity, and therefore it will be on the basis, and the VQ matching will get better when you take the sternum off and when you prone it. So yes, it will work. I'm absolutely agree with you that it will work, but just have to be careful because suctioning and preventing the tube from clotting is also very important. So you have to be very careful, and suctioning does become difficult when you are proning. But yes, I agree with you, Dr. Marinda. You have no choice. If somebody is not oxygenating and you have PF ratio is less than 100 and you have no choice but to, I'm just warning you that you got to treat it not like a pure ARDS, but it has to be treated more like a DAH. And the number one, because you're asking me what is the principle of management of the ARDS in this, my principle is do not cause bleeding into the bronchial mucosa with a suction catheter. That is my advice to management of this patient.
Agreed, sir.
Sir, role of tranexamic acid as a nebulization, and second is like you are mentioning Novo 7 via the endotracheal tube.
So I was telling this thing before. So we have tried all these things initially using, because to save say use 0.1 milligram of Novo 7 through the bronchoscope and try to spray it like a fine mist. It doesn't work. To be honest with you, we have wasted and we have made an effort. There is no real data to say that these things work. Whether you aerosolize it through a nebulizer, haven't tried that, but we've tried to put it through a scope in various aliquots and made it into small aliquots and like doing a wash of various segments and put it. But then you end up having clots, and it really doesn't make any useful suggestion. But these are all last ditch efforts which we have tried, and those were the heydays of Novo 7 when when everybody was using Novo 7 left, right, and center. So I think we have evolved that way. We understand that there is specific role for Novo 7, and this probably, and to use it at the right dose with the, and to wait 2 hours doesn't work, then to use more. That will probably be the best thing to do.
Just to add on, sir, we had one patient on ECMO whom we did a tracheostomy, and she bled into the post procedure, and in that case also Novo 7 injectable form
Correct.
helped us.
Correct.
So,
Absolutely.
the last few complicated scenarios, sir, where we face, I think probably some of this we have discussed, a patient with simultaneous bleeding and thrombosis. I think probably
Yeah,
Srinivas
I
sir
think we
already.
discussed this. Yeah, we discussed this. I think, as I said, so that is why I think documenting the whether minor bleeding ongoing, not to react to it with more of tranexamic acid, and to have the understanding that not to use too much of Novo 7 unless it's a major bleeding and things like that. And major bleeding means that you're requiring transfusion to keep the hemoglobin up, you're requiring those kind of things unless those are happening, or you have deep seated bleeding. As sir rightly pointed out in the first thing itself, platelet dysfunction leads to more to mucocutaneous bleeds and bleeding from sites rather than deep bleeding. So you will end up having ooze from the procedure lines, from the endotracheal tube, which will have to be taken care of. And then if your hemoglobin is okay, not be in a way to try to give too much of agents which will cause thrombosis. Use sequential compression devices, whatever is feasible to keep the patient hydrated to prevent thrombosis from happening. That's what we'll have to say. Uh, and for your CRRT and ECMO, I think CRRT, at least we can use a citrate anticoagulation rather than to use heparin. ECMO, I would not be, don't know whether we can, what we can do we've had patients who are actively bleeding and we've stopped the heparin and still the filter works for some time. So it does work, and it's not like a heparin low heparin or whatever they call it. But yeah, it will be dangerous to give heparin and to cause create problems of this thing and to lead to a problem here. That is no doubt about it. So citrate anticoagulation for CRRT, regional citrate anticoagulation.
And for DVT, I think we discussed you can use short-acting low molecular weight heparin, monitor the anti-factor 10A level if you have GT with DVT. Atrial fibrillation needing anticoagulation, difficult situation. So you have to do the scoring for atrial fibrillation. What is that? You have to quantify. Yeah, correct. So you have to quantify the risk of thrombosis versus the risk of bleeding with the Glanzmann. We'll have an idea of how severe the Glanzmann is. We'll have an idea of how high the score is as far as the risk is concerned. If the thrombosis risk is high, the score is high for atrial fibrillation, people have used apixaban successfully even in Glanzmann thrombasthenia patients. We have used it. Generally, you start with the lowest possible dose.
Okay. I think there has been one question from the audience, sir. What would be the ideal timing of using factor 7?
In the chat.
And should we meet the traditional criteria which have been described, when you are using Novo 7? Because this is always debatable in especially patients with a normal a DAC or a bleed where early Novo 7 versus late Novo 7, sir. So probably I think that is a question what he was trying to ask.
Yeah. So in the context of Glanzmann thrombasthenia or any platelet function defect, so always grade. So low grade bleeding, intermediate grade bleeding, intense bleeding. So if it's intense bleeding, there's no timing. You start it as soon as it's available, as soon as possible. Ideally, start up and titrate down if it's very severe bleeding. As we discussed, neuraxial bleeding or ophthalmologic bleeding, you do not compromise. You start with full dose and then you titrate down as required. So the dosing also we discussed. So intense bleedings, don't wait, start as soon as possible. So either SDP or factor 7A, whichever comes first. Typically, you give SDP first, and then you give factor 7A to stabilize, to maintain control over the bleeding, so that you don't have to use further platelets. If it's mild to moderate bleeding, you can wait. You can try the antifibrinolytics, where you don't think, if you don't think that life or limb is at risk, then you can use full dose antifibrinolytics with DDAVP. Remember, DDAVP won't work for more than 2 days. So 2 days is a limit. And if that does not control the bleeding, then you can go to factor 7A, so as to avoid platelet transfusions. If you are asking about the timing of factor 7 before surgery, it should be done immediately before the surgery in the OT itself. As we discussed, it has a very short half-life. Factor 7A has a very short half-life, and you do it immediately before surgery while the patient is being anesthetized. It's a 5-minute infusion. You give it slow IV bolus over 5 minutes.
I think that was a really an extensive and exhaustive discussion, sir, because I think probably you have discussed, most of the common things for an uncommon condition, which we rarely come across in the ICU. And I think a lot of expert inputs, and we must thank, Manindra for bringing up this case. And I think probably Srinivas sir probably for managing this patient successfully. Thank you, Suresh sir and Srinivas sir, for your valuable inputs, for making this, discussion very fruitful. Thank you, sir. Thank you so much, sir.
Thank you very much.
Thank you. Thank you very much. I learned a lot from you guys. Thank you very much.
Good evening to
Thank
all.
you.
Bye.
Thank you, Suresh sir. Thank you, Srinivas sir.
See you, Manindra.
Bye.
Salam.
Thank you, sir.